There were a couple of reasons. I mean, there have been studies indicating that cardiogenic shock patients after the acute myocardial infarction are the group of people that are at the highest risk. And these studies that were done over the past couple of decades have shown that the trends of mortality are actually going down, and it had been attributed to prompt revascularization. But there have been no studies which are specifically designed to look at those group of patients where they had a heart attack or an acute myocardial infarction, and then they have cardiogenic shock, and they do have a PCI within 24 hours. So this is the set of population that we believe are benefiting and that we are doing a good job. So I wanted to see the national trends of how we are managing these patients when we are treating them promptly, and that was one of the motives behind doing this study. And the reason I chose Cath PCI registry is because it's been shown to have good fidelity data. It's a national database registry with around more than 5 million database of patients who underwent PCI with a very good fidelity that's already been published with a data quality program that's robust. And so that's why I decided to do this study with the NCDR. The primary motive of this study was to look at outcome trends and change in baseline characteristics. And we do see that the female proportion of patients are actually declining, and we see that the rates of smoking history is declining. We see rates of PAD and chronic kidney disease declining. We see that operators are using more of bivalirudine, less of heparin. But there are some discouraging data regarding pre-procedure loading of aspirin and Plavix or clopidogrel or any other thienopyridine, where the rates of dual antiplatelet therapy are less than 60% before a PCI. Other than that, we see that most of these patients are coming with multi-vessel disease. That means apart from the culprit vessel, they have significant other diseases, which are more than 70%, and yet the operators are not choosing to do more than the culprit vessel, which is what the guideline actually does give room for multi-vessel PCI in the setting of hemodynamic compromise. But we see that national operators are staying away from that and just treating the culprit vessel. We also find that discharge medications, we are not doing a good job because the trends of patients discharged on aspirin and dual antiplatelet therapy are declining. Even though statin discharge therapy is good, but there is still around 20% of the patients not discharged on statin. The most important study outcome is the study results are the outcomes, and we find that despite all the good things we think we are doing, we are using balloon pumps, we are using latest medications, we are doing prompt revascularization with great door to balloon times, we see that the mortality is increasing, and there was an unadjusted mortality increase from like 26% to 32%. Agreed that this is historic compared to the historical data for cardiogenic shock, this is lower, but when you specifically look at this group who got good PCI, their mortalities are increasing, and when we adjust for all the variables, this trend still holds true. So we have an increase in adjusted mortality from 2005 to 2013, and it essentially raises the question whether is there something we are missing? Is there a piece of the puzzle that we are not aware of, or is it just we are looking at a sicker group of patients who inherently at a higher risk, and this is probably the nadir of the best, the mortality that we can get to them, and probably this is the best we could do. But at the same time, it actually gives room for more introspection to see what things we could do. And as we saw in the clinical trends and demographic trends and medication usage trends, there is still a room for improvement, and maybe this might help us in changing the outcomes. There are some good things we are doing also. As we see in the outcome trends, when you adjust for all the variables, there is a decline in bleeding, which is very encouraging, and which probably speaks to all the propaganda of bleeding avoidance strategies that we have been portraying to all the operators, and now the operators are more cognizant of the hazardous impact of peri-procedural bleeding on outcomes, and probably they are using more bleeding avoidance strategy like radial access, increase in bivalirudine use, have good system processes like sheath pull team, and which are very important because in our study 95% patient got femoral access. Not only from the access standpoint, but these are the patients who require big sheath and big French size catheters for ventricular assist devices and other stuff. So I think the fact that bleeding, despite use of these bigger catheters and sheath sizes, bleeding rates are improving is actually a very encouraging sign, and so are the rates of blood transfusion are declining. Stroke rates have remained unchanged. To conclude, I think we have also found some predictors which are different than previous studies. And a very interesting, apart from the fact that presence of cerebrovascular disease, diabetes portend poor in-hospital mortality, we have found some negative predictors, and especially the more important one is a female gender. All previous studies before, with regards to ACS, with regards to PCI, with regards to cardiogenic shock, have shown that female gender is actually a positive predictor for in-hospital mortality or short-term outcomes. Ours is the only study which actually is showing that it's actually has a protective effect with regards to in-hospital mortality. So it seems that although females are at higher risk when it comes to ACS and cardiogenic shock, but when they do get prompt PCI, they actually outscore the men with regards to in-hospital mortality. And other variables associated with favorable in-hospital mortality were a BMI less than 30 and a history of prior PCI, which is again interesting compared to no PCI, which probably reflects the fact that these are a group of patients that are well connected to the health system, are on good medical therapy, and when the event happens, they probably are on best medical therapy, know exactly where to go and stuff like that, which probably helps them out, or probably the concept of ischemic preconditioning that's helping these group of patients. I think there are a couple of things from the operator standpoint. From the operator standpoint, we have found that this balloon pump utilization has gone down, and when we looked at predictors, we saw that the placement of balloon pump was kind of related to a worse in-hospital mortality, especially when placed before the PCI, which probably may just reflect the fact that the operator chose to put it because the patients were sick, but essentially it raises the questions of whether these devices actually do help us. So unless there is I guess the operators need to weigh the risk and benefit of using these support devices, because they have to consider bigger sheath sizes, makes the procedure a little bit more complicated. So maybe I have a higher threshold to use them, because there is still no supporting evidence either before this study or any other study to support the usage. But what essentially my study shows is that these group are, it underscores the fact that these group of patients are sick patients. No matter what we do, no matter how we do, these people have inherently poor outcomes to begin with. But our study did shed light into the deficiencies in some of the in-hospital management that we could still improve upon. So I think that would be a message to take home. And also it's also a pat on the back for some of the operators who are doing good bleeding avoidance strategies. The bleeding rates are going down, transfusion rates are going down, which do indirectly impact mortality. So I think this is a reflection of what we are doing that we should continue to do, which is good, and maybe also raises some question that we need to introspect our practices to see what else we could do to kind of stem this rise in mortality. So essentially, from the operator standpoint, it gives a perspective of what new devices or what new medications and what treatment strategies should be changed. But from the research standpoint, it also raises the question that is there something else that we need to do to stem the tide of increase in mortality in this group of patients.